I use it in the operating room, and I use it selectively. Perhaps it could benefit more patients, but I primarily am trying to do it in patients who I deem at intermediate to high risk, or patients who have unexplained lesions or positive cytology where I can't see anything specific with white light. So I think there are going to be dramatic changes. So the current guidelines are recommending use of enhanced cystoscopy if it's available. And really it's up to urologists to make enhanced cystoscopy available for their patients. I think if you can find more cancers earlier, it is going to impact recurrence rates and possibly progression rates. And certainly if you have patients that you think are responding to therapy such as BCG, but in truth you're missing carcinoma in situ, then you're really under-treating some patients who have BCG-unresponsive disease, for example, who should either get their bladder removed or go on clinical trial. So I think there are going to be some dramatic changes for patients and also urologists who are going to have to change their clinical practice patterns. Again, I think it's really going to benefit patients early in their care. So for example, at the 3-month visit after their initial TUR, they're at highest risk for residual or recurrent disease. I think those are patients who will probably benefit the most. I think also in patients who are undergoing BCG treatment, often we do see unexplained red lesions, and I think that the blue light cystoscopy will help determine whether or not those are ones that should be biopsied. And certainly in patients with carcinoma in situ, I think every one of those deserves to have blue light cystoscopy in clinic. There are very few areas where we have randomized trials that demonstrate a significant benefit to patients. And this is one area where there's a significant improvement. And I think if you told a patient that, hey, we have a technology that is really non-toxic, very quick to use, I would say relatively inexpensive, that it makes sense to do it for patients. And I think that patients definitely would want to have any technology that would improve the treatment of their current cancer. Certainly, urologists and any physician who has been doing cystoscopy and taking care of bladder cancer patients for a long time feels like what they're doing is the best thing, and that it's difficult to change what you do. But I think we have to adapt to new technologies. We have to embrace them. And the fact that we have randomized trials showing a benefit is really sort of critical, that we learn from these experiences and not just say, well, it's good that we have it. We really have to change what we practice and really accept them. In bladder cancer, I think we have a responsibility when we do have randomized trials to take that information and change what we do, especially for intermediate and high-risk patients who might benefit significantly.